Picture this scenario. You're sitting in an emergency room. The fluorescent lights are humming, that sterile smell is everywhere, and you feel like you are slowly slipping away. Your limbs feel like they're made of lead. Your brain is in a fog so thick you can barely answer the triage nurse's questions. You know deep in your bones that your body is shutting down. You tell the doctor, "I am in an adrenal crisis," but the doctor looks at your monitor. Your blood pressure is normal. Your potassium is normal. You don't look like you're dying. So they tell you you're anxious. They tell you to go home. And that is the most dangerous moment of your life. Today, we're talking about the invisible cliff edge of adrenal insufficiency. We're looking at why the medical definition of a crisis and the patient's experience of a crisis are often two completely different things, and why that gap can be fatal.
It's a terrifying gap, Noah, and it really comes down to a fundamental misunderstanding of what cortisol actually does. We often hear it called the stress hormone, and people think, oh, stress, that's just feeling overworked. But for someone with adrenal insufficiency, or AI, cortisol isn't just about stress. It's the fuel for the engine. It's what keeps your blood pressure up, your blood sugar stable, and your heart beating. Without it, the machine simply stops.
The article from My Adrenal Life that we're looking at today uses this incredible image of walking a tightrope. And I think that's where we have to start. For a healthy person, if you trip, you catch yourself. Your body has a safety net. But for someone with AI, the net is gone.
Exactly. The tightrope walker is a perfect analogy for the daily maintenance of this condition. But to really understand the energy deficit these patients live with, I often turn to Christine Miserandino's spoon theory. She originally wrote it about lupus, but it applies beautifully here. She explained that a healthy person wakes up with unlimited spoons. Every task, showering, driving, working, costs a spoon. Healthy people don't have to count. But if you have AI, you wake up with maybe 10 spoons. A shower costs 2. Dealing with a stressful email costs 3. If you get a cold, that costs 5. Once you're out of spoons, you don't just get tired, you crash.
And that crash is the crisis. But here is the tension I want to explore. The article mentions that patients often sense this crash coming long before they hit the floor. They feel the worsening. But the ER doctor is trained to look for the body at the bottom of the cliff. They're looking for shock.
Right. In emergency medicine, an adrenal crisis is defined by objective, catastrophic failure, severe hypotension, that's dangerously low blood pressure, uncontrollable vomiting, and often unconsciousness. It is a state of shock. But the biological process leading up to that state begins hours, sometimes days before. The patient feels the sliding scale of symptoms, the severe fatigue, the dizziness, the nausea. They are shouting, "I am falling," and the doctor is saying, "But you haven't hit the ground yet."
That distinction is chilling. I am falling versus you haven't hit the ground. One of the most confusing parts for patients, and honestly for some doctors too, is that not all adrenal crises look the same. You have primary adrenal insufficiency, which is Addison's disease, and then you have secondary and tertiary, and the symptoms in the ER can be radically different. This is the single biggest cause of that ER disconnect we mentioned. To understand it, we have to look at the anatomy. In primary AI, or Addison's, the adrenal glands themselves are destroyed, often by the immune system. The adrenal cortex produces two main things we care about here: cortisol and aldosterone. Aldosterone is the salt hormone, right?
Precisely. Aldosterone tells your kidneys to hold on to sodium and release potassium. If you have Addison's, primary AI, you lose both cortisol and aldosterone. Without aldosterone, you pee out all your salt. Your blood volume drops, your potassium spikes. This creates a very clear, very dangerous blood panel. You will see low sodium, high potassium, and low blood pressure. An ER doctor sees those labs and immediately thinks, adrenal crisis.
Okay, so primary patients usually have the textbook lab results that scream emergency. But what about secondary AI?
Secondary AI is different. The problem isn't the adrenal glands, it's the pituitary gland in the brain. The pituitary isn't sending the signal, the ACTH hormone, to tell the adrenals to make cortisol. But, and this is the crucial part, aldosterone is controlled by the kidneys, not the pituitary. So in secondary AI, the aldosterone system still works.
So their salt and potassium levels are
Normal.
normal.
Yes. They have normal electrolytes. Their blood pressure might even be normal until the very last second, but they have zero cortisol. So they are suffering from severe hypocortisolism, lead limbs, brain fog, impending cardiovascular collapse, but their blood work looks fine. This is the trap. A patient walks in saying, "I'm in crisis," and the doctor checks the sodium and potassium, sees they are normal, and assumes it's not adrenal related.
That is a terrifying blind spot. It explains why so many patients in the article describe feeling gaslit or dismissed. They are technically dying of low cortisol, but they aren't dying of low sodium, so they get sent home.
And unfortunately, sent home in that state can be fatal. Without stress dose steroids, the body eventually cannot maintain blood pressure solely on aldosterone. The system collapses. It just happens differently than in Addison's.
I want to go back to the history of this for a moment. You mentioned Addison's disease. It's named after Thomas Addison, a British physician from the 19th century. I was reading about his monograph from 1855 on the constitutional and local effects of disease of the suprarenal capsules. The descriptions he gives are almost gothic.
They really are. Addison was working at Guy's Hospital in London, and he was a brilliant diagnostician, though by all accounts a very melancholic, difficult man. He noticed a group of patients who were fading away: anemia, general languor, feebleness of the heart. But the most striking feature was the skin. He described a peculiar change of color. Their skin turned dark bronze or greenish brown.
The bronzing. That's specific to primary AI, right?
Yes, and the mechanism is fascinating. When the adrenal glands are broken, the pituitary screams at them to work. It pumps out massive amounts of ACTH. The molecule for ACTH is very similar to the molecule that stimulates melanin in the skin. So the body inadvertently tans itself while trying to jumpstart the adrenals. Addison saw this bronzing and realized these patients all had damaged adrenal glands, usually from tuberculosis back then.
It's tragic, though, because while he identified the disease, he couldn't save them. There was no synthetic cortisol in 1855. A diagnosis was effectively a death sentence.
It was. And Addison himself had a tragic end. He suffered from severe depression, what they called melancholia at the time. He retired in 1860 due to his health and committed suicide just a few months later. It's a somber legacy for a man who essentially founded the field of endocrinology.
That context adds so much weight to the diagnosis. We aren't just talking about fatigue. We're talking about a condition that was universally fatal until the mid-20th century. Now, fast forward to today, we have hydrocortisone, we have prednisone. We can keep people alive, but we still have this issue of the worsening symptoms. The article lists impending doom as a symptom. That sounds dramatic, like something from a novel, but it's a recognized medical sign.
It is absolutely a medical sign. In the context of a pheochromocytoma or adrenal crisis, a sense of impending doom is documented in medical literature. It's not just anxiety. It is the physiologic brain response to a massive drop in perfusion, blood flow, or a chaotic hormonal signal. Your body knows it is dying before your conscious mind understands why. Patients describe it as a primal certainty that something is wrong deep inside.
So when a patient tells a doctor, "I feel like something is wrong," they aren't just complaining. They are reporting a physiological status update.
Exactly. And this brings us to the concept of stress dosing, or sick day rules, which is the tightrope walker's safety pole. Because the body cannot produce more cortisol on demand, the patient has to do it manually. If they break a leg, get the flu, or even have a massive emotional shock, they have to take extra steroids immediately.
The article mentions that sometimes people worry about whether they are heading toward a crisis and whether they should take the extra meds. There's a fear of over-medicating, but also a fear of the crisis. How do patients navigate that?
The general rule in the adrenal community and among endocrinologists is, when in doubt, dose. The risk of one unnecessary dose of hydrocortisone is negligible compared to the risk of an untreated crisis, which is death. but this requires the patient to be their own doctor in real time. They have to assess, is this headache just a headache, or is my cortisol dropping? Is this nausea from lunch, or is my body shutting down? It is an immense cognitive burden to carry every day.
And that cognitive burden is compounded when they go to the ER and have to explain it to a professional who might not be an endocrinologist. The article suggests that patients might need to change their language. Instead of saying, I'm in crisis, saying, I am experiencing severe adrenal insufficiency symptoms that may lead to crisis.
Language matters. If you say, I'm in crisis, and you are sitting up talking, a busy ER doctor might subconsciously disqualify you because you aren't in shock yet. But if you frame it as, I have a history of adrenal insufficiency, I am vomiting and cannot keep my meds down, and I need IV hydrocortisone to prevent hemodynamic collapse, you are speaking their language. You are giving them a problem, vomiting or absorption issue, and a solution, IV meds.
It's managing up, essentially. You have to manage your medical team while you're barely conscious. I want to touch on the iatrogenic or steroid-induced cases. We have primary, Addison's, secondary, pituitary, and then this group who maybe took steroids for asthma or arthritis, and now their bodies stopped making cortisol. Do they face the same risks?
They absolutely do, and they are perhaps the most at risk for being overlooked. If you've been on high-dose prednisone for months for, say, rheumatoid arthritis, your HPA axis, the hypothalamus-pituitary-adrenal loop, goes to sleep. It stops trying. If you suddenly stop those meds or if you get sick, your adrenals are atrophied. They can't wake up fast enough. These patients often don't even know they have adrenal insufficiency until they land in the ER. They don't have the medical alert bracelet yet. They don't have the bronzing of Addison's. They just have a collapse.
The HPA axis really is like a thermostat that's been turned off, isn't it? You can't just expect the furnace to blast heat the second you flip the switch back on.
That's a great analogy. The pituitary is the thermostat, detecting the temperature, cortisol levels. The adrenals are the furnace. In steroid-induced AI, the thermostat has been seeing high heat, the medication, for so long it stopped sending the signal to the furnace. The furnace grows cold and rusty. When the medication stops, the house freezes.
So, wrapping this up, the core conflict is between the slow slide and the sudden drop. The patient lives on the slide. The doctor treats the drop. How do we close that gap? The article emphasizes education on both sides.
It starts with validation. Doctors need to trust that a patient with AI knows their own early warning signs, that specific flavor of fatigue or flank pain that signals danger. And patients need to be equipped with emergency injection kits, usually Solu-Cortef, so they don't have to wait for the ER to get that life-saving dose. The golden hour in trauma applies here too. The sooner you get the cortisol, the less likely you are to need the ICU.
It's a powerful reminder that in chronic illness, the patient is often the expert in the room regarding their own physiology. If you know someone navigating this tightrope, or if this episode sheds some light on that invisible struggle, please pass it along. It might just give someone the vocabulary they need to survive that next ER visit.